So good morning, everyone. So my topic is rotablation case-based discussions. So of late, we have been seeing calcium, recognizing calcium, kind of calcium, what's there inside the coronary artery, and dealing with that. And we are enhancing and bettering our performance. So this was a case when I was doing an acute interval MI STEMI, and nothing was going in after 1.5 millimeter balloon. And to our surprise, this patient had a very severely calcified lesion, and I had to take rotablation in acute interval MI. So whichever case you are doing, you can't avoid these kind of gadgets. And to be familiar with these gadgets, you have to see cases, do cases, and then perform cases, and finally you can give outcome like this. So this patient uh, was okay in 24 hours. We discharged the patient. So let's go around the algorithm of calcium, how we detect it. So we have got scoring algorithms now, OCT based and IVUS based. And what we see is the arc of the calcium, the length of the calcium, the thickness of the calcium, and the vessel size, which we see in IVUS. And we get a calcium score and we decide our strategies. But this is also very important, what kind of the calcium distribution patterns are. So this is basically a very superficial calcium and concentric calcium. This is very well treated by rotablation. This calcium, the second one, is deep calcium, although concentric. So this rotaburr is not going to touch this calcium. So no way you can perform rota in these cases. IVL is the method of choice. Similarly, when there is eccentric calcium, which is superficial, be it a calcific nodule, it's well treated with rotablation, provided your wire is biased towards the calcium. So we have got a misconception that rotablation creates havoc inside. We really scared that rotablation, this rotating mechanism, is going to rupture the artery, disturb the artery, destroy the vessel, the intima and everything. But it is not true. You see here, the left side, there is a artery which has been given angioplasty with a balloon. And you can appreciate here the number of dissections in the artery. And right side, it was after a rota run. So rota gives you a clean artery. Rota ablates and cuts very precisely, and the artery which you have after a rota run is very clean, unlike your angioplasty balloon. So this fear is totally unfounded and totally out of proportion. We shouldn't be fearing rotablation if you know the basics and how to perform it. It works just like an electric razor. You see, when we cut our, when we shave, it cuts our hair, but doesn't cut our, the skin. And that is how rota works. When it encounters the elastic tissue, it doesn't, cut it. When it encounters an inelastic tissue, it cuts through. And that is why it cuts the calcium, it cuts the fibrotic plaque, but seldom cuts the, intima. So let's get ourselves familiar with rotablation system. So rotablation, now we have got RotaPro. This is the, the gold standard, not gold standard, the original RotaLink, which we have been using for last 7-8 years. So they both have a console and an advancer and a paddle. So the paddle is not there in RotaPro. On the advancer, there is a knob which you activate, then the rotablation starts, and again you push it, then a rotablation stops. So everything is under your control in RotaPro in your hands. But in RotaLink system, the paddle is there and console is there, and an advancer. We'll go through in detail. And this burring motion, the increased speed, facilitates the advancement burr. So just like opening a champagne, your fingers doesn't get hurt. It's not easy. Just do it and it goes off. So the speed, the burr usually advances. You don't have to push it through the tissues. And the plaque the particles which you get after, the rota burr, the rota runs, these are about less than 5 microns. So they don't clog the vessel usually. So you don't get a no flow situation. You can get a slow flow situation, very rarely no flow. And all these pass through the capillaries and they are taken care by the reticuloendothelial system, afterwards. So nothing is retained there in the microcirculation after some time. That is the basic. And this is a console. There is a dynaglide and a foot pedal. and there is an air tank is there, and there's a compressed air or nitrogen you can keep in the air tank. I will go through all this in detail because it's important to know the hardwares. In cardiology, interventional cardiology, 80% job is done if you know the hardwares, what French size, what is, what's the lumen there, and what kind of gadgets you are using. So this Rotalinks console has got a tachometer where the rotational speed is displayed. There is an event timer. There are connections through which you connect with your saline and the advancer. Then there is a turbine pressure knob through which you can control the pressure, and there is a power switch and a power lamp. And this is the air tank. The pressure in the air tank should be something around 500 psi, not 500 to 700 psi. But in the console, it should be around 90 to 100 psi. It's not more than that, and that is controlled by the knobs which are there in the console system. And Dynaglide you can activate by just pushing the side button, which is silver in color, smaller knob. You press it, and then it lightens up, and it shows that now it is Dynaglide mode. Now you can switch the paddle, and the Dynaglide, it will move in a Dynaglide fashion. Dynaglide means the rotational speeds is not something like 150, 170. It's just half of that, 70 to 90. So it doesn't injure the vessel. You can just take out the wire after activating the Dynaglide mode and switching the paddle. So this is how it works. And sometimes some of the operators you must have seen Dynaglide mode, they activate to advance the wire. Sometimes wire comes in. You have parked the wire in the distal LED or distal RCA. You've activated the foot switch. Now we are doing a rota, and now you see the wire has little come inside the mid LED. So if you want to park the vessel, some of the operators, they bring the switch on the Dynaglide mode, and then activate the rota and pass the wire in. So that is not a great idea. Although very seasoned operators like Dr. Samim Sharma has shown many times, but the company discourages about doing these things. So it's Dynaglide mode is always to withdraw the wire, the exchange the wire. And then we have got an advancer. Advancer has got multiple knobs. So this is basically the advancer knob. In RotaPro you press it and go forward. In Rotalink the switch pedal works, and you go forward and backwards with this knob. And then there is a wire brake system. There is you have multiple connectors, and then there is a drive shaft through which the rotabar is attached here. One of the most important component which one should know is rota wire. So rota wire is unlike 0.014. What we generally has basically the normal thickness of the wire which we use. This is 0.009. And it tapers down to 0.0077, then 0.005 in the distal. Then again, last portion is 0.014. So that is why if you take your rotabar towards the spring coil, it is going to snap it off. So you have to leave the opaque part of the rota wire while you are doing a rotablation. So there's nothing is more opaque. Little distal segment of 30 millimeter is opaque. So you don't have to go, your rotabar should not be approaching this area. It should be proximal to that area. And then the rota drive extra support has got uniform 0.009 thickness till 5 centimeter. And beyond that, it tapers down 0.005. So there is no transition from 0.009 to 0.0077 to 0.005. So this directly tapers to 0.05.